First of all, thanks, Paul, for allowing us to do this. Hopefully, I'll spend maybe about 15 minutes, I hope, talking about vitamin D, and as you can see on the title, its relationship to potentially for preterm birth prevention. And I do want to say, just because I got burned by this once before, I have no conflict of interest in giving this talk. I paid my registration. I don't think Paul's writing me a check for being here this morning, and I received nothing from Grassroots Health. That is a lie. They did my vitamin D level for free, and I was deficient. This slide I'm not going to go through. It's an oh my God slide, just to remind myself and everyone else that when I went to medical school, vitamin D was involved in bone mineralization, and that was it. When I went to medical school, there was no such thing as a cytokine. They were inflammatory pyrogens. So we have learned tremendous amount about the functionality of vitamin D over the last 20 or 30 years. And actually, we now realize that vitamin D is much more of a hormone than it is a vitamin. It serves as, really the introduction of the slide that Paul showed is very true. It's involved with activation of DNA activity, enabling the DNA to respond to various signals in multiple body systems. And again, its aspect as an inflammatory mediator in the human body, I think, is probably the aspect of it that makes it important in terms of potential relationship to premature birth. There are huge, and you may know this better than I, there are huge controversies involving vitamin D in terms of what the appropriate dosages are, what the appropriate supplementations are, what its role are in multiple other aspects of medicine. It is a huge issue in childhood asthma and respiratory, inflammatory, and immune conditions. There's a huge role with it's thought to be very related to multiple sclerosis, cancer. It's in many other areas of medicine. What I found, unfortunately, is that in obstetrics, we are not a huge stakeholder in some of the fights that are going on out there over what represents the appropriate supplementation. Many people have been going back and forth with the Institute of Medicine recommendation, which is essentially to classify vitamin D deficiency as being less than 20 nanograms per milliliter. And as we go through our talk, or this talk, what I would hope to point out is that the target goal for our patients needs to be a vitamin D level, ideally between 40 and 60 nanograms per milliliter, which is far higher than all of your patients are currently measuring, and I'll show you data on that. I got into this at MUSC in Charleston, really following on the coattails of two of our people in our pediatrics department. Dr. Carol Wagner and Dr. Drs Hollis have both done prospective randomized trials looking at high-dose vitamin D supplementation. In both of their trials, they had 400, which is the recommended supplementation currently, versus 2,000 versus 4,000 international units a day in the NICHD trial. And in Wagner's trial, they dropped the 400 and just supplemented with 2,000 versus 4,000. And they were looking at safety issues primarily. They had to get an IND to be able to give 4,000 IU per day. They found, in their published studies, they found no issues with safety, no issues of toxicity, no adverse events. And of course, they've looked at the outcomes. And in that study, one of the most important outcomes, first of all, let me show you the results of the vitamin D levels achieved by the three groups. And it's a little bit hard to appreciate from this slide. Most of the people had vitamin D levels that were raised to between 35 and 40. It's easier to look at on this slide, which shows the achieved vitamin D levels, and there were significant differences between supplementing with 200 to 400. With 4,000. Only with the 4,000 did they get a mean vitamin D level up around 40 nanograms per milliliter. And what I would ask you to notice are the error bars, the standard deviations, which are huge. which I think underscore two things. One is compliance, obviously, as with any supplementation, but the second is tremendous biological variability in how we respond to supplemented vitamin D. And that's something that what we really have discovered is that you can't just give a certain dosage and expect it to be effective. You do have to follow these levels up. In both of, and this is data from the combined NICHD trial and the Thrasher Research Foundation cohorts of over 500 patients, what they found was that the incidence of preterm birth prior to 37 weeks was almost 60% lower for those women who achieved 40 nanograms per milliliter versus those who had levels of less than 20 nanograms per milliliter. This is, shows you a Lowe's curve relating the weeks of gestation at birth to the vitamin D levels, and highlighted in this the little box in the middle, you can see a progressively rising gestational age at birth between 20 and 40 nanograms per milliliter. After 40 nanograms per milliliter, and most of the patients made it up to like 60, some of them to 80. It really kind of plateaus. But between 20 and 40 nanograms per milliliter, which is really the area of interest because it corresponds to the varying definitions people use as to what represents vitamin D deficiency. Institute of Medicine says less than 20. Some other organizations say less than 30. We would recommend trying to achieve greater than 40. This is just a blown up looking at the same curve with the confidence bands. Again, as you look at the x-axis down there of the serum vitamin D level, between 20 and 40, you get a progressively rising gestational age at the date of delivery, and then some plateauing after that. Basically the same thing, looking at it a different way with hazard ratios. This is not only our own findings, this is another prospective randomized trial by Wagner, which found essentially the same thing that we did. This data is listed as another way that the vitamin D levels get expressed as millimoles. But for those patients who achieved in the Wagner study greater than 75 millimolar, their preterm birth rate was 7.3%, as opposed to 11.3% for those who were less than 50 millimolars, corresponding to about 20 versus 30 nanograms per milliliter. Meta-analysis of looking at several different studies all concludes the same thing, that if you're deficient, less than 20 nanograms per milliliter, you have about a 30% increased risk of premature birth. And if you're insufficient, less than 30, about a 25% increased risk of preterm birth. So after really assimilating this, doing these randomized studies at our own institution, we decided we were going to do a field trial, which was basically to implement vitamin D screening and supplementation at MUSC. We started approximately 2 years ago. We did vitamin D screening as part of everybody's initial prenatal blood work. We responded to that with vitamin D supplementation. Grassroots Health was kind enough to provide us with free samples for vitamin D. However, the vast majority of patients received simply prescriptions for supplement that they filled themselves. The goal was to get them above 40 nanograms per milliliter. We followed up their vitamin D testing at the time of their glucosylscreen. Grassroots Health helped us with educational modules for our obstetrical providers and nurses on the result, really by Dr. Wagner, reviewing the work that had been done and the goals of treatment. Population, our mean age, we have a diverse population, about 32% black and 8% Hispanic. Just confirming what you will find almost everywhere else that you look, you can find it in your own population. worse if you have a very high rate of people of color in your population, but 90% of our population had a vitamin D level of less than 40 nanograms per milliliter. That became 97% in the African American population. And you can see that pretty much across the board, 67, if I gotta put my glasses on, 67% of our African Americans had a vitamin D level below 20 nanograms per milliliter. In our white population, that was 16%, and overall a third of our patients had vitamin D levels. We get vitamin D levels back that are 7, 11, 14, I mean, clearly dangerously deficient. Between September 2015 and January 2017, we took care of over 3,000 patients. These represent the number of tests that were done. It took a while to ramp this up, get everybody on board, but about 2,500 patients were tested. About 800 patients had more than at least 2 tests done. So we followed, again, just kind of documenting the implementation of the program. For those patients who had a second test, our supplementation did increase their vitamin D levels from a mean of 25 to 37.9, which is, again, what we expected to find and we're pleased to find. This is just a colorful slide showing the distribution of our vitamin D levels. Even with this effort, only about 14% of our patients were able to get greater than 40 nanograms per milliliter. And again, I think a lot of that was hesitancy on the part of many of our practitioners to be as aggressive with supplementation as we encourage them to be. We have delivery information on about 1,400 women who had at least one vitamin D test. There were 15% preterm birth less than 37 weeks. 50 of those were less than 32, 23 were 32 to 34, and 134 were 34 to 37 weeks. If you compare the preterm birth rates for women who had their last vitamin D level was less than 20 nanograms per milliliter versus greater than 40, we had a 56% reduction in the rate of preterm birth, obviously a significant difference. For those that we were able to get from 20 to 39, it was a 37% reduction in their preterm birth rates, both of those significant differences. If you plot, again, this is similar to the plot that from Carol Wagner's preterm birth study. You can see again the rising preterm birth rate, significant rising, term birth rate or gestational age at delivery between 20 and 40. If you superimpose, this is again from Carol Wagner's randomized trial, you can see how it mirrors almost exactly the experience that she had.
Roger, could you point out the very preterms, like less than 34 weeks?
Let me go see if I can go back. Well, these are the very preterms down here, late preterms up here, moderate is 32 to 34, and less than 32. And again, this is just a blow up of the risk or gestational age at delivery. Based on the 25 hydroxy vitamin D levels. So what we're doing now is we are continuing to collect the vitamin D data on these patients and look at their pregnancy outcomes, analyzing the data. Literally, we just collected it, the last bit of data we collected yesterday. So there are a lot of other variables that we have to look at. There are a tremendous number of confounding variables. But we were thrilled by the similarity between what we found in our clinical intervention, our clinical field project, and the results of the randomized trial that was done at our institution. Again, we're actively participating in almost all of our clinics now. And I mentioned that Grassroots Health was providing us continuing educational materials as well as vitamin D supplements. We're going to look at other pregnancy outcomes, all of which have been associated with vitamin D deficiency. And I would tell you that any of you that are interested in possibly doing such an intervention at your institution, that's Carol Baggerly. She's the executive director of Grassroots Health. They are a nonprofit organization out of San Diego, and they would be very happy to work with anybody to try to extend this. So there are tremendous numbers of unknowns in this area, but what we found in our field trial, matching up with several other prospective randomized trials showing a relationship between achieving these vitamin D goal objectives and reduced preterm birth, make it something that's exciting and interesting and something that I think obstetricians should become more interested stakeholders in. Thank you. That's all I have.